And this is a continuation of the discussion that started in Arlington, Virginia, back during the Direct Primary Care Summit on June 15th, actually. The hour-and-a-half session that we had on the first day of the summit. And this happened as a result of interest among direct primary care model practices that would like to find ways to become part of an employer's benefit plan, to be woven into the fabric of a benefit plan. And the general discussion about how direct primary care can enhance an employer's health benefits and actually lower their costs. So, and this is actually facilitated by the Primary Care Innovators Network, which is a collaboration between Employer Advantage and Family Medicine for America's Health and the Family Medicine Education Consortium. We are honored to be part of that collaboration in helping improve the circumstance for primary care in order to help them improve the circumstance for the patients they care for. And we feel that the direct primary care model is the best representation of what true investment in primary care can look like. And so our conversation today is going to really touch on what the best strategy might be for you if you're interested in working with employers. And as I've said earlier, weaving yourself into the fabric of the employer's health benefit offering. So when we look at this, what we want to do is think in terms of how can you maximize the employer's offering to their covered individuals? How can you make it truly of value to the point where they see the value of working directly with primary care in order to address some of the unmet needs of the covered individuals? So from that standpoint, we often suggest that it's important to understand a good place to start is to recognize some of the legal issues that an employer faces when they sponsor a health benefit plan, that there are regulatory requirements associated with that process. And it will depend upon whether that employer is either fully insured, in which case it'll be a state insurance set of regulations, or if they're self-funded, in which case then it will be federal regulations that apply. And but understanding that shows a meaningful level of respect for an employer, so that they in turn will feel better that you have taken into consideration their issues and are not just thinking about the plight of primary care. Certainly it's an opportunity to bring that to everyone's attention, but it may not necessarily be the best way to go in each case. Many employers already offer on-site, near-site strategies, and to understand exactly what that conversation has been about, to determine whether or not it's available to everybody who's covered under the benefit plan, or is it more of an occupational medicine type of offering? That's important as well, because then there are regulatory requirements, if you will, that go into an employer who offers an on-site, near-site, in the sense that they have a certain level of accountability and liability for that strategy. And in working with you, you may well be in a position to mitigate that or actually limit the liability for the employer who has chosen an on-site, near-site type of strategy as part of their benefit plan offering. Again, it's important to understand what employers are required to offer and think in terms of really what they want to offer instead. Because the type of employer you want to work with, and we'll talk about this in a couple of minutes, but the type of the employer you want to work with is one who sees this as a way of supporting their covered individuals, their employees and their dependents. That's really where you're going to find the most rewarding opportunity to work collaboratively with someone. The other piece of this is you can help the employer meet their obligation, but not necessarily do so in an uncontrolled fashion. I often will point to preventive care, for example, and the requirement to offer preventive care under the ACA, and the fact that the chances are real good that that requirement to offer preventive care, if you will, is going to carry into whatever repeal and replace strategy emerges. But the deal is, frankly, currently, and I don't see it getting any becoming worse in a replacement strategy, but the deal is that the primary care practice or the preventive care benefit, I should say, doesn't have to be available through every primary care practice. The preventive care benefit, for example, the employer can decide that it's only available from a limited number of practice sites because they can trust that practice site to deliver true preventive care as opposed to just an annual physical. Legal compliance, again, we'll talk about some of the issues that employers are facing, particularly self-funded employers, as they endeavor to remain compliant with federal law, IRS law, and the like. So, okay, so this, frankly, should be viewed as, what is that employer's position on this whole thing? Do they see this as an obligation, or do they see this as an opportunity? Because we did talk at previous sessions about really finding employers that you want to work with, because not all employers are made equal, frankly. Not all employers' hearts are in the right place. Not all employers' minds are in the right place. And so in order to be successful, you really want synergy to exist between yourself and the employer. And so frankly, you really want to look for those employers who see the offering of a benefit plan as an opportunity, not as an obligation. You want to find those employers whose efforts are really aimed at supporting the needs of their patients. So from that standpoint, you want to look at what's the employer's position in terms of the Affordable Care Act, because if they are simply trying to comply with the Affordable Care Act, that may not necessarily be an employer that you want to work with. The Affordable Care Act lays out certain required benefits that have to be in place, but including, for example, preventive care. There were still, there were many employers who held on to the so-called grandfather status as long as they could they made zero changes in their benefit plan in order to avoid having to adopt things like preventive care. That may not necessarily be an employer you want to talk to, because that employer was unable to reconcile and recognize the value of primary care and the value of preventive care. So you want to take their pulse in the context of the Affordable Care Act. And as such, you really want to dig into and delve into what that employer's culture looks like. What are their goals for their employees and covered dependents? And what sort of commitment do they really have to their workforce? Do they genuinely want to offer the best possible arrangement that delivers the most supportive services to their covered individuals? Or again, are they simply doing what they have to do? In those instances, again, they may not be someone that you want to even waste time talking to, because their ability to really appreciate everything that primary care can do for them and do for their covered individuals may be pretty impaired based upon their perspective that they're fulfilling obligations as opposed to seeing this as a genuine opportunity. When you start talking to an employer and you're talking about the subject of near-site care, on-site care, understand that they have certain requirements that go into that. And many of them were simply trying to get closer to some sort of medical advice, medical director type of insight. Well, the simple fact is you can position yourself as the medical director for that employer, as the trusted advisor. And you'll see repeatedly that your ability to distinguish between the services you provide and the healthcare services that are reflected in their claims data or claims paid information, you need to make the right type of distance between yourself and that information, because you want to position yourself to be the go-to person for the employer who is looking for insight regarding the best possible way to finance and deliver healthcare services and on behalf of the covered individuals that they have, so that the services are truly aligned with the needs of those covered individuals. And I've used this term before, and it's really just a term of art. It's not really any sort of regulatory designation or licensure of any kind. But if you can get the employer to view you and see you as almost their purchasing agent for healthcare services under their sponsored benefit plan, and you've established that trusted advisor type of relationship with the employer, then you've created a considerably more powerful, frankly, position for yourself to not only be an advocate for the patient, ensuring that the patient receives what they need when they need it, but creating an environment so that the patient is, the employer rather, recognizes that in terms of patient care, you are being very prudent and you are not only paying attention to the needs of the patient, but you're also able to help make sure that the plan remains affordable by seeking care on behalf of that patient that is the most cost effective, the most efficient, the most effective. And that you're willing to re-examine some of your referral relationships if new information becomes available to you, and you're then able to see the benefit of making a change in the way you refer your patient or share your patient with specialists and other types of providers. So in that setting, you really do begin to change up the relationship you have with that employer. And now, lo and behold, you're actually sitting on their side of the table as opposed to being perceived as some sort of natural adversary that is simply looking at making the health plan more expensive. Now, when it comes to establishing certain definitions for the employer to better understand the value of your style of primary care under the direct primary care model, by establishing yourself again as that trusted advisor, you then become the source of definitions, one of which is preventive care. What does that really mean for a patient, a person? Is it an annual physical? Well, frankly, no. Frankly, annual physicals are provided because that's what's been paid for in the past, and that's what's been perceived as of value. Well, we've discovered, many have discovered, that it's more about a conversation than it is an examination, and that a true preventive care visit is able to uncover a much broader array of issues and challenges that the patient has that will, yes, have short-term effects, but more importantly, longer-term effects that could translate into real money to the employer, particularly the self-funded employer. So to be able to help that employer understand that making healthcare, or primary care rather, closer in terms of proximity is certainly one thing, but making it fit better definitions of care delivery is yet a better thing. So to help the employer understand what true preventive care looks like is important. Likewise, to help the employer understand what true wellness programs should look like creates truly a business opportunity for community-based direct primary care model practices, because then they can receive the dollars associated with that employer's efforts at wellness. And in some instances, you may be the wellness vendor for a patient, even though you're not their regular doctor, meaning they may not have selected you to be their regular doctor, but because you're the source of wellness programming for that employer, you nevertheless have an opportunity to interact with that patient and possibly get them to recognize the value of coming to you as their source of primary care. But more importantly, you're able to define what wellness programming looks like inside a clinically valid environment and give the employer a better understanding of why wellness programs, frankly, need to be more tailored to the needs of the individual, rather than these broad brush education programs where information is thrown at the population, hoping that it resonates with somebody. Likewise, when managing a disease state, to take into consideration everything that's happening in the patient's life, if you will, or their circumstance, taking into consideration the so-called comorbidities is also important. And that then provides the opportunity for you to help the employer understand that a disease management program that you and your practice team members might offer would be considerably more effective in its efforts, because again, it's placed now inside a clinically valid environment. It's no longer a faceless nurse on the telephone from 3 states over. And as a result, the employer's investment in disease management is going to be considerably more effective if they are working with a real doctor in that sense. Likewise, with care management, care coordination, there are a lot of transparency programs and efforts and initiatives that have been put out there in order to guide people through the healthcare system more effectively, ultimately guiding them to, quote, cheaper care. Well, the reality is that there is so much information that patients just don't possess, that to expect them to self-direct through the so-called healthcare maze, when a lot of the information they're getting is, it sounds like it applies to me, but I'm not sure if it does. Well, let me do it anyway because it might. Well, the relationship with primary care under this model, where the primary care practice is given the opportunity to not just manage the care of the covered individual, but also coordinate where they receive the care, that practice is able to do so more effectively, more intelligently, because they're able to fill in the gaps of understanding that patients inherently have, and why many of the transparency programs are either poorly used or not used at all, because I have no idea if I even need an MRI, let alone finding out where the cheapest one might be. So we really like to see an environment where some of the motivation the employer had to go near site, on site is better supported, frankly, through a community-based primary care relationship. And frankly, now, if you will, the liability for these services is consolidated in a clinically valid environment that has a better chance of mitigating those risks by better understanding the needs of the patient than something that is freestanding and siloed, where a patient says, well, you know, they sent me here, meaning the referral management company, without regard to the patient's actual needs. And so care was either delayed or unnecessary care was actually provided. That's not likely to happen in a trusting relationship with a primary care clinician. And then finally, frankly, probably the most important development that we've begun to see is around the research done by the University of Oregon around patient engagement, high-level activation. Highly activated patients are inherently healthier and 10% less expensive to care for. So the research suggests, why aren't we all kind of rowing in this direction? Why aren't we trying to make an effort to do this? Well, many are. Patient engagement, if you will, as a model and concept or strategy has been pursued by health plans for some time now. The problem is, the reality is, the health plan doesn't have the same relationship with a person that a primary care physician and his or her team might have with a person. The efforts around successful patient engagement and high-level activation really call for a trusting working relationship in order for the person to feel more comfortable taking the insight and information from the care team and then feeling confident in their ability to assist in their own care needs. So the ability to present yourself as the source and capability for not just engaging with people, but also getting them to a state of high-level activation is, I think, an emerging opportunity that's pretty significant. And again, will help the employer avoid some of the pitfalls of some of the programming they've offered that has bordered on violation of equal employment opportunity laws, Disability Act laws. By putting the person in a more clinically valid environment, it removes the employer from appearing to be involved in something that's trying to manipulate their covered individual based upon some condition they might have. So I mentioned earlier, when we talk about compliance, it essentially falls into two buckets or two flavors, one of which is the state Department of Insurance. Now, if you live in a state like New York, like I do, lo and behold, we have found a way to regulate it twice. We regulate it under this Department of Insurance, the New York State Department of Insurance, but we also regulate it under the Division of Insurance inside the New York State Department of Health. So, you know, bless our hearts, and maybe I mean that in a good way, we have figured out how to regulate things twice. But that's for smaller employers. That's for fully insured employers who are working with a state licensed health plan in order to offer their benefits. For the larger employer, the self-funded employer, where they're using their own money to pay claims, they fall under the ERISA rules, the Employee Retirement Income Security Act, which really expects that the resources are spent wisely. And ERISA also applies to retirement plans. And so an emerging issue, interestingly enough, is the fiduciary responsibility of an employer being called into question around whether or not they are successfully spending money wisely, or whether they are knowingly allowing or inadvertently allowing waste. And so this falls under their fiduciary requirements, because the money actually, once a claim is paid, is deemed to be the employee's money at that point. They have exercised their benefit, and they have received compensation for that benefit in the form of a claim payment. Now, if more money was spent than was necessary, then that's where the problems begin to occur. And that's where this issue is becoming to gain some traction, frankly, as worth exploring, because so many interesting deals, if you will, have been done between health plans and hospital facilities, for example, where is that price for that service? Is the delivery of that service as efficient and effective as it could be in order to protect the employee's money? Because again, it becomes the employee's money once a claim is paid. So if $5,000 was spent when $2,000 should have been spent, then the question arises, did the employer waste $3,000 of the employee's benefit dollars in not paying attention to what's going on? So it creates an interesting opportunity for primary care to serve in the role, as I said earlier, of purchasing agent and watchdog, to ensure that monies are spent more intelligently, more efficiently, more effectively. And so that is creating yet an additional opportunity for primary care to kind of become involved in something in order to protect the interests of the employer, while at the same time they are successfully able to advocate for the employee or covered individual. And as we know, self-funded employers are exempt from the state's departments of insurance. And as such, it really is an opportunity for a self-funded employer whose claims are being administered by a licensed insurance company to really help the employer understand that maybe some of the things the licensed insurance company is suggesting are straight up unnecessary because you're not regulated by the state insurance department, but their administrative procedures are imposing those regulations on you. So there's been quite a bit of talk around the impact of the current Internal Revenue Service rules on the payment of the direct primary care membership fee. This was a question we had come up at the earlier session, because under present IRS rules, the membership fee cannot be recovered from HSA proceeds. The membership fee in and of itself is not currently deemed by IRS as payment for medical services, because it's pre-payment for medical services. IRS rules limit themselves to post-payment for medical services. So in that instance, the employer who offers a high deductible HSA plan needs help and guidance in order to enhance the plan and support the offering of a primary care model in innovative ways. And we've been able to develop such innovative ways in support of some of our clients who offer high deductible health plans by focusing on what are known as disregarded services. These are a range of services that the IRS has suggested, or has presented rather, based upon their rules, that these services are not subject to deductible, and they're not payable under an HSA plan anyway, and so they don't jeopardize the HSA plan. And the disregarded services fall into some interesting areas, because typically these are services that the employer has vendored out to a company to provide and are deemed not part of the health plan's standard benefit offering. They are, again, disregarded services. And those are wellness services, disease management services, care management, care coordination services. And we've already talked about earlier today, and we've already talked about at earlier sessions, the strategy, the concept of positioning primary care to be the purveyor or vendor or deliverer of wellness programming, disease management programming, care management, care coordination programming. This creates an opportunity for the employer, frankly, to be compliant with the IRS rules, yet offer a considerably broader range of benefits available through a primary care relationship. In addition to preventive care, the employer payment on behalf of the covered individual, the employer payment of the membership fee on behalf of the covered individual, can also deliver these additional services, everything up to, but not including sick care, and as such, give the covered individual a considerably more valuable primary care program that is able to really not just deliver true preventive care, but is actually able to get this person well on the way toward a healthier state through wellness programming, through disease management support, and through care management, care coordination efforts. So it really does create an opportunity for the high deductible health plan employer who sponsors such a plan to really recover, frankly, some of the perceived takeaways that occurred when they moved in the high deductible health plan direction, and really send the right message to the covered individual, to the employee, that the employer really cares and is working very hard to create an environment where more services, supportive services that really align with their needs, are available at no deductible, no out-of-pocket expense when delivered by the correct community of primary care or direct primary care practice with whom the employer now has a relationship. In addition, many employers offer what's known as an employee assistance program, and these are typically low-level behavioral health type services that support the individual who is having various life challenges, if you will. Well, when you consider the level of behavioral health that's offered, in many instances, a primary care, frankly, has been trained to some degree to provide that, and certainly nothing would preclude primary care from establishing a relationship either on an ad hoc basis or some other structured arrangement so that low-level behavioral health is co-located or embedded in the offerings of the practice. So again, it's that opportunity to expand and be of greater value to the employer in their efforts to remain compliant with current rules, yet still offer something that is viewed as being of tremendous value. So we put this under the label of what we call enhanced primary care, because we really want the employer to see this as that. We don't want them to see it as necessarily a complete revision of their benefit plan, but we want them to be able to understand the argument and the value of making sure that their covered individuals are not medically homeless and have a meaningful relationship with primary care. So, we sort of present this, we suggest you present this as an enhanced primary care strategy. But long before you get into exactly what it is that you offer, you really want to have this evaluative conversation with the employer so that they are able to see exactly what the impact can be. And it's how well aligned it is with the needs of their covered individuals. So, but you want to also have them understand that this free primary care model, if you will, enhanced primary care, is only available through the correct community of primary care that is ready, willing, and able to be prudent in how primary care is delivered, how focused primary care is on the needs of the covered individual. Doesn't mean that they can't continue to offer traditional forms of primary care, certainly, but it doesn't mean that that primary care should not be subject to deductible and copay. The employer, while they're enhancing the program or their plan, they really want to make sure that they're not shoving people into it, if you will. They want to make it available, make it obvious that it's in the enlightened self-interest of the individual to do it. But they also want to make sure that traditional primary care, if you will, is still available. But there is a consequence, a financial consequence for the covered individual who chooses not to take advantage of the enhanced primary care model. The other element is to make sure that the employer understands and the covered individual understands that the same rules will apply in terms of accessing specialty care and specialty care services in the sense that the deductible will still apply, the copay will still apply. The primary care team might be able to find those services at a lower unit price, but ultimately it's the same benefit plan design that impacts specialty care and specialty services, and really helps to establish the fact that enhanced primary care is placing primary care at a much higher, more valued position than other types of healthcare services that someone might otherwise access through their benefit plan. The same service limitations will apply if only certain amounts of care are covered under the benefit plan for specialty care, for example. It really reinforces the fact that a meaningful working relationship with primary care can actually help the covered individual avoid meeting or exceeding those service limitations. And in addition, if there are specialist or facility carve-outs, there are so-called centers of excellence that are being made available on the benefit plan. A trusted relationship with the primary care practice will give both the employer and the covered individual some comfort in knowing that you're going to be a little bit better at making sure that folks end up in the correct facility if that's indeed what has been established. And frankly, as the trusted advisor to the employer, if you want to help the employer better understand whether or not they're buying something that's of value through a carve-out, you'll be in a position to do that as well. So you can kind of help them make sure that their benefit plan is as fine-tuned as it should be in order to make sure it operates effectively in terms of providing for the financial needs, but making sure that folks are receiving high-quality care, not just in your practice, but downstream as well. So we've been at this for about 40 minutes or so. So at this point, what I'd like to do for those of you who have joined us today is open it up to questions. And I would invite, Cinnamon, if you would facilitate this, that would be great. But I would invite questions that fit any of the previous topics that we have touched upon in the previous sessions. So feel free to either talk about today's session or any of the other previous sessions if you joined one of the previous ones and didn't get a chance to ask a question, or if you did, or if you witnessed the recorded version and would like to ask a question now. Feel free.
Okay, thank you, Jed. So everybody, let's ask Jed some questions. If you are joining us from computer, all you have to do is click the microphone icon on your screen to unmute yourself and ask a question. If you'd prefer to type a question into our group chat box, you're welcome to do that as well, and I'll read that. Or if you're listening in by phone, you can unmute yourself by pressing *6.
Well, I evidently did quite a thorough job.
I would say so, but I know we have to have some questions out there. Okay, we do have a question, Jed. It says, is it possible to see the recorded prior sessions? And I can answer that one for you, Kyra. It certainly is. I can send you a link to all of those prior webinars if you would like. I do have your email address. I'll make a note of that now.
I have a question.
Yes.
Can you hear me? Yeah, this is Amy Coleman, and I was just listening along. I was interested to know, as a physician coming to a employer, how open are employers to actually talking about this to physicians? Because in past times of working with corporations, I felt like I'm in a room with a CFO who really needs to know kind of accountant type information, and I always feel like I'm kind of missing a person there for a moment. I'm like looking over my right shoulder wishing my accountant was with me.
Yes, and frankly, that's the service that we have provided on behalf of the employer, frankly, because we think the employer benefits from that ability to translate the conversation as much as the physician benefits from that ability to translate the conversation. And it's why we're preparing financial information that will be made available through Family Medicine for America's Health that points to the real dollar impact. And so, but you make a good point in terms of the concern you have, because the employer needs to understand first, and it depends upon who you're talking to. And frankly, I'll be honest, the CFO is the correct person to talk to, because if you want to disturb complacency, you have to help them understand the real dollar impact you can make. And we've seen as much as 20% differential, that for someone who is comfortably situated inside a direct primary care model practice, we see a reduction in downstream spending that translates into about a 20% savings. Some have seen as high as 30, but in our experience, we've seen about a 20% savings. And so at an earlier session, the physician said, how do I present the information about wellness and all? I said, well, frankly, you don't. What you do is you open the conversation by exploring with that employer what their perspective is around enhancing primary care for purposes of reducing the aggregate spend. Again, explore their perspective presently, listen carefully, and then guide them from where they are to where they need to be in understanding how healthcare is delivered, and that, or could be delivered, I should say, in a true primary care driven environment, and what sort of impact that can make on aggregate spending. And the easiest place to pick on, and certainly you want to review the most recent information around the Institute of Medicine's discovery, around 30% of healthcare spending is just pure waste. JAMA has a recent article about low value care. It really can equip you with the kind of sound bites you might need in order to really have more of a CFO type conversation. So you really want to see it as an opportunity to better understand where they're coming from and see where they could be using this kind of strategy. But frankly, it's been a role that we have served in a community. In many of the communities we work in, we've been invited in by somebody, either by an employer who heard about this and wants to really explore it, or by a primary care practice that needs help talking to an employer. But since we're always a vendor to the employer, we will often do that in an effort to support the development of the model in the community, and not necessarily charge the primary care practice anything in that sense.
Thank you, Jed. One last little piece of that is how often do you find yourself speaking to the human resources and the CFO rather than the CEO or owner of the company?
Well, we would prefer to speak to the CFO, and frankly, we would prefer not to speak to human resources.
Right, I agree.
We have discovered that folks in human resources don't want to work that hard.
That's right. Mm-hmm.
They don't want to disrupt anything, and they're often not accountable for the spend related to the benefit plan. So, there are
many wellness operations that are, I won't name the name of it, but that go through all of their wellness programs. All their wellness programs are focused through the human resources department, and I felt like that was a flaw. I felt like it was taking power out from the hands of doctors and nurses.
Yeah, it is. Well, I feel like this. I affectionately refer to it as practicing medicine out of the human resource department.
Exactly. Thank you. I appreciate your insight. Thank you.
You're welcome.
Thank you, Jed, and thank you, Amy, for the question. Jed, we have a couple more questions in our chat box here. John Leeper asks, is DPC membership an allowable expense under an FSA or HSA plan?
Yeah, and again, I touched upon that a little bit earlier, but it's always worth reinforcing that under the current system, the membership payment is designed to be payment in advance of care, not payment for care. And because of that small little perspective, if you will, it doesn't fit the strict definition of a reimbursable expense, either under a flexible spending account, which is an FSA, or a health savings account. Now, it is reimbursable under a health reimbursement account because it's the employer's money. And in that instance, we're simply suggesting the employer simply pay it directly and not launder it through an HRA. But for an FSA and an HSA, where a receipt of some kind is necessary in exchange for services already provided, that's been the challenge. And so that's why the Direct Primary Care Coalition has been working on getting the Enhanced Primary Care Act passed in the House and the Senate and signed by the President, because that immediately changes the IRS definition, which then frees it up for the HSA, and likewise for the FSA, because those are pre-tax dollars, and that's why it falls under IRS rules.
Jed, how does that, oh, I'm sorry.
Taxing strategy.
How does that calculus change for those of us who bill, you don't bill in arrears, you bill at the end of the month when you've provided the month of service of availability?
Yeah, and that's been the flaw in those states that have written DPC legislation, and it's the disconnect that exists between state level legislation and federal regulation, because the efforts for states to adopt DPC laws has been aimed at removing DPC from any sort of insurance definition, but it hasn't addressed the language in the IRS rules. So, you know, it's been, yeah. So the state level regulations around direct primary care have been to allow you folks not to be viewed as a form of insurance under state laws. It hasn't addressed federal regulations.
And secondly, how do you actually get to the CFOs? I'm finding all the HR people obstructing.
Oh, sure they are. They're afraid. Yeah, they're afraid you're going to disturb their, their life. And so it really, Doctor, is positioning yourself in the same circles as positioning themselves in the same circles as where the CFOs hang out. We mentioned this earlier in terms of joining service organizations like Rotary or Kiwanis, becoming an active member in the local Chamber of Commerce. So raising your profile so that you find yourself suddenly standing next to the CFO of a company. The benefit of getting into that circle is important because you may not be of any service to that CFO's company, but CFOs tend to hang with each other as they try to explore new ways of improving the bottom line. And so and many of these groups of chief financial officers are informal. There's really no public meeting place per se. And so to start talking in a collaborative and informative way to one chief financial officer may well open the door for you to talk to other chief financial officers, because really the person you want introducing it to human resources is the CFO, where you guys have had really this kind of collaborative conversation to the point where they say, well, this is something we really want to explore. So I will direct my human resources department people to put this in place. It really is an uphill slog when you're talking to someone who it perceives almost immediately that you're going to screw up their life, make their life more difficult. And that's really ultimately not what happens. I mean, we have seen the nice transformation of HR people, but it's difficult because they really don't. I mean, I have a master's in human resource administration. I know these fine folk, and they just don't want to work that hard. So
we need to find a stalking strategy to get to the CFOs.
Yeah, that's. I mean, hey, I apologize, but that's you gotta be a CFO stalker, and again, if you consider that you're running a business, which you are, and you're wearing multiple hats, which you are, you're both the CEO and frankly, you're often the CFO, let alone the COO of your own company, and so. Improving your bottom line is a conversation you want to have. And frankly, this business model for primary care is one of the best ways to legitimately improve your bottom line, because you're changing up the payment methodology and making it more of an investment in your practice rather than a payment for care. So, but stalking, I'll go with that.
Sounds like you've had to do this before, Jed. We have We have one more question in our chat box. It says, could you explain more about how disregarded services work with a DPC model as it relates to an employer's benefits package?
Absolutely. And this is something where we refused, as an organization on behalf of one of our clients, we refused to take no for an answer. So we took the IRS rules and we broke them apart. And we really explored exactly what the IRS was trying to accomplish. And frankly, it's not that the IRS was all that intelligent. It's just that the IRS, and that's why the word disregarded is so cute, because they didn't want to examine things that the IRS perceived were not part of healthcare delivery. And so when they started to explore the way employers were offering things, they discovered that employers were vendoring out wellness programs, disease management programs, and care management, care coordination services. And so the IRS perceived that, oh, those are disregarded services because the employer vendors those out. So those will never be subjected to a deductible or payable under an HSA plan because the employer is paying a vendor for that. Well, our approach, and the great news is we got the support of some pretty recognizable attorneys in the development of language that supports the notion of disregarded services being delivered in a primary care setting by establishing that primary care practice as the vendor for those services in the same manner that some other company, a non-practice company, would be designated as that vendor. So that really is the painful level of detail that we had to go through in order to skin that cat, because we refused to take no for an answer. We refused to allow the current process of care, which fragments the heck out of wellness, disease management, and care management, care coordination, that undermines the effectiveness of those strategies. So our feeling was, let's just really understand the regulations and the rules, and then write the documents to fit the regulations and the rules such that the primary care practice can get that designation legitimately from an employer, and the employer in turn doesn't have to work with some virtual company that's 3 states away. They can work with someone who's right there in their community.
Thank you, Jed. Everybody, we have another 4 or 5 minutes or so. We probably have time for another question if anybody has one. Okay, Jed, it looks like we don't have any further questions at this time. I'd just like to let all of our participants know that I have posted Jed's email address. If you think of a question later, you're welcome to email Jed at jconstantz@eahcs.com. We've also recorded this webinar today, and that recording is going to be made available soon. We'd like to thank you all for joining us today, and we hope you all have a good afternoon.
Excellent. Thank you, everyone.